So when they went back and looked, if you remember that slide that showed the tower or pillar type structure of biofilms, when they sampled at deeper and deeper levels of the biofilm, they found that the concentration of oxygen drops to essentially zero at the lowest layers of the biofilm. So those cells underneath are in varying states of dormancy. In the field, they're referred to as persister cells. And we know that most bacteria, or most antibiotics require oxygen to be effective, and most antibiotics require that the bacteria be growing. So in a typical biofilm, if you treat it with antibiotics, you may just kill the actively growing cells on the surface, and the cells underneath will remain dormant so long as you're administering antibiotics. Now here's just an image showing what that looks like. At the bottom is the substrate the biofilm is growing on. The biofilm bacterial cells are shown in the red. The media is on top, and then it's just the cells highlighted in yellow there, stained in yellow. Those are the only ones that are actively growing and synthesizing protein. Now here's some modeling from the Center for Biofilm Engineering at Montana State University, and we're going to watch 300 hours in the life of a biofilm, just compressed down to 12 seconds. And it really illustrates these persister cell phenomena. This reflects the common tool used in biofilm research, the live dead stain. If they're live, they're in green. If they're red, they're dead. And over that 300-hour time span, at time equal to 100 hours, we're just going to add a pulse of antibiotic and see what happens. So here we go. You see the biofilm growing. When we get to time equal to 100 hours, when we add antibiotic, it kills all the bacteria on the surface. But then as we go forward in time, those dormant cells gradually can re-emerge from dormancy and regrow a quite robust biofilm. So that's just a very, very quick introduction on biofilms. Oftentimes gives a little bit more detailed presentation on that. But now moving to what we're talking about today, the ASPS system, which, as I mentioned at the beginning of the talk, one element of the ASPS system is low energy ultrasound. And here was a study, an animal study done in rats, and it showed that if you apply ultrasound to rats with these little mini silicone implants, there was actually a quite dramatic and significant effect on the histology of the capsule. Specifically with respect to ultrasound and biofilms, there's a number of published studies that show that this type of non-contact, non-thermal, low-frequency ultrasound therapy can enhance the healing of chronic wounds. One of the studies came from the Mayo Clinic. They found a significantly greater percentage of wounds healed in the presence of ultrasound, and they healed at a significantly faster rate. And then there were a couple of other studies also looking in the clinical setting at non-contact, non-thermal ultrasound with similar findings. Now, there's some studies that were done actually at the University of Utah where they actually had pieces of silicone elastomer implanted subcutaneously in rabbits. And they looked at using antibiotics alone or antibiotics together with ultrasound. And they found that the combination of ultrasound with the antibiotics significantly increased the effectiveness. Here's the first data. On the left, you see that solid bar. They grew a biofilm on a little polymer disc, and that's how much bacteria was on that disc. Then they put it subcutaneously in the rabbits and administered in this study vancomycin. And then in one group, over the last 48 hours of the 72-hour study, they applied ultrasound. And you see in the rightmost set of columns, the one combined with ultrasound is in the darker color, and there was a statistically significant reduction. And then here's the second study from that group. This, in this case, looked at E. coli, and you see a statistically significant reduction in the number of bacteria. In this case, it was Staph epidermidis or Streptococcus in this one, with the presence of ultrasound as well. So at this point, what I'd like to do is shift gears, and Tim Wyant, who developed this technology, will explain just a little bit to you about what it involves and how it works.
Good morning, everybody. Whoa, here we go. Thank you, Roger. My name is Tim Wyant. I'm a physical therapist, and I'm a developer of the ASPS system. What I'm going to do is take from what Roger's discussion was on biofilm and integrate another component of treating breast implant capsular contracture. And I'm also going to bunch this term of contracture as complications in breast surgery regarding shape and malpositioning. in the formation of scar tissue, not so much as defined as contracture, but an abnormal formation of the capsule, thicker, creating position changes. As Dr. Wickstrom had discussed, capsular contracture has a bacterial component. We all know that with infections, hematomas, seromas, this increases the risk. We've also found that in our practice, which is based in South Florida, we've seen a number of components regarding genetic predisposition to certain ethnicities. We have no data or research on this. This is all our personal findings over demographics. And what we've done with that is we've created an assessment tool to take any patient that we see post-breast augmentation and come up with a more objective measure as to the number of things that we see that will give a clear diagnosis on a complication like contracture. Number one, the most traditional methodology being Baker gradient scale 1 through 4. Malpositioning or shape distortion. As you can see in this picture, we do pretty complex photo analysis and measurements of the shape and malpositioning. We actually find that that's better than hands-on or Baker grade evaluation. Any presence of pain, either transient or constant. Another test being a patient lays down on their back, supine anterior projection test. If that breast stands up on its own, it's probably not a good sign. And a few other presentations of myofascial restrictions within the pec, incisional depression, and a history of CC, of course, is a good indicator that there's probably going to be a likelihood of continued contracture with surgical revision. We based all this from the research on frozen shoulder adhesive capsulitis of the glenohumeral joint. We took what we knew in physical therapy and we basically applied it to breast implants. It's the basis of how we do what we do with the ASPS system, which is not just external ultrasound. It's actually very specific physical therapy in combination with the ASPS ultrasound. Again, we know hematomas, seromas, bruising are precursors to the onset of contracture. We also provide a prophylaxis in our clinic in which a patient who has bruising, seromas, or hematomas, we will actually pre-treat these patients under the idea that potentially this patient is a higher risk for developing contracture. These are just some of the patients that we see. Again, you can see the classic superior migration of the implant here on the right breast. Again, on the right breast, this was a Baker grade 3 firmness on the right. Left breast, again, classic upward and medial migration of that implant, creating that shape and position distortion. We also treat patients post-reconstruction with radiation, which has a higher incidence of contracture. These are really our babies, if you will, in our practice. Very aggressive contractures, and we put a lot of time and effort into treating these patients. Again, post-radiation, reconstruction. One of the things that we see also, especially with infraareolar incisions, when a patient contracts, we'll actually see a dimpling of the incision. We use this again as a clinical diagnostic tool to confirm diagnosis of contracture or early onset of contracture. With the ASPS system, again, combined with the ASPS technique, which is essentially physical therapy for the breast capsule, we can see significant changes in the shape of the breast with this, which is essentially softening and loosening the capsule. Combined with the ASPS ultrasound series is a very specific form of massage and capsule mobilization that we do. The whole point of this is to actually create a elastic to plastic tissue deformation, which is where anybody who believes the traditional myth of using ultrasound treats contracture and probably get very disappointing results is because ultrasound creates a change within the capsule, but it's normally never permanent. And that unless it's combined with the aggressive massage and the specific bandaging procedures that we do, you typically tend to see that elastic return of the capsule rehardening for patients kind of where they started all over again. In our practice, we do a specific bandaging procedure in which we will actually provide a compression to the top of the patient's breast to push the implant down and keep the capsule on the stretch, similar to what you would do with burn patients, splinting them to keep that tissue elongated. We actually do that with the breast as well. This is just an explanation of ultrasound. Ultrasound can be used in many, many different forms, high intensity, mid intensity, low intensity. One of the things that we warn again with the Aspen ultrasound system with popular myth and anecdotal information, a lot of duplicate devices are out there such as LipoX, DermaWave, and there's a million other devices. These devices are not proven or nor have any research to treat contracture. And again, because it's a very small segment of what we actually use to treat, which is changing the capsule shape, we warn that duplicating with specific technologies can be actually pretty dangerous to a patient. As you can see here on the left picture, the Aspen ultrasound series uses very, very large transducers. Surface area is key to coverage when treating contracture, again, as part of the total treatment program. You can see there on the right side, a traditional ultrasound wand being about 10 centimeters does not give you a whole lot of distribution of your ultrasound. And why is this so important? The reason why this is, and again, my joke, and I say this a lot, is using traditional ultrasound wands for treatment of implant contracture is like cooking a steak with a lighter. You have too large of a surface area, and a wand is not able to cover that. The reason why that is because ultrasound is temporospatial, meaning the amount of area over time and space. Hence the design of our system being so unique. Again, key points to this: ultrasound must be relative to the surface tissue that you treat and its size. Our system, the Aspen ultrasound system, is computer controlled, meaning you don't use a wand to run over the area. You actually apply it over the top of the patient and you leave it sit on the patient, and a computer controls the delivery of it to the tissue that you're treating. And again, ultrasound is an adjunct to the overall program, not a treatment by itself. This is the Aspen ultrasound series. This is the technology that we designed as part of the Aspen treatment. Other considerations when treating your patients with breast implant contracture. As we all know in the business of surgical revision, the outcomes of surgical revision of contracture can sometimes be less than desirable due to the fact that contracture has a high recurrence rate. Secondly, how does this affect the plastic surgeon's business? Well, you don't really want patients walking around unhappy with bad results. We know it's not your fault. I know it's not your fault. Your patient doesn't know it's not your fault. So patient retention and reputation is hugely important. Of course, lawsuits and litigiousness, the goal is to make your patient happy with the outcomes of the surgeries that you do. The Aspen system is a very affordable adjunct that you can put into your office as an alternative to surgical revision. Okay, thank you very much. I'd like to now present Dr. Kress, who has been utilizing the Aspen system in conjunction with antibiotics, and he'll be speaking on his experience with it.
I don't want to be too loud. My name is Don Kress. I'm a solo practice plastic surgeon in rural Maryland. We've had the Aspen system since November of 2010. I did receive travel expenses from Aspen. Other than that, I'm a consultant for Sientra breast implants. Over the period of time that we've had the Aspen system, we enrolled 38 patients, 4.7 average treatments, 2 times a week was the basic system. 35 of the implants were gels, 3 salines, 16 implants subpectoral, 22 subglandular. 2 patients were post-mastectomy reconstructions. We changed Tim's system a little bit. We put everybody on a scale of 1 to 10. We evaluated them on position of the implant, hardness of the implant, and discomfort. When we ran the data on the position and measured the changes in the position after the treatments, we noted 16 patients were unchanged, 22 patients showed improvement. The improvement was statistically significant at 0.001. And the numbers in this form don't really mean too much, but the pre was 4.08 on a scale of 10, and the post was 2.7. We also ran a discomfort scale. Again, the P was significant at 0.001, 19 were unchanged, 21 improved. And again, you can see the percentage of the improvement. We also did hardness scale. 17 patients were unchanged, 21 were improved. And you can see the pre and post numbers. When you take all three parameters together and evaluate who improved, 26% of the people had improvement in all three parameters, 29 and 2 and 26 and 1. Only 18% of the people had no changes whatsoever. More importantly, when you ask the patients about their satisfaction with the ASPS system, 52% of the patients were satisfied with the ASPS system and they had no additional treatment. 21% of the patients, because I am a surgeon, they opted for surgical revision a little quicker than they would in some of the other practices. So 21% opted for surgical revision after just a few treatments. 15% are still planning surgical revision, and 10.5% dropped out of the study. And I have an explanation of why the ones dropped out in just a few seconds. So the limitations of my particular study, it's a very small size and it's very preliminary. Obviously we had self-reporting of discomfort. There's no objective way of doing that. Short duration of the study, but of course we're planning on keeping this going. This is very, very promising data. Basically our conclusions for a preliminary study, small size series, we thought it was a great positive benefit. For a non-surgical procedure to get more than 50% satisfaction of the patients is incredible. The ultrasound massage method from Aspen, when evaluated on the three parameters, was statistically significant in all three parameters. Patient satisfaction was, as I said, over 50%. No patients had any worsening of any of their symptoms from the Aspen system. This, I don't have the little lines on there, but clearly the left breast is rounder, harder, higher. After this is about 8 treatments, the inframemory fold is in the same position and there's a softening of the breast. Same issue, the left breast is higher and rounder and harder. After a few treatments, it's down again, about 6 treatments. It's a little bit more dramatic, severe capsular contracture, but still significant softening, drop down into position, and she moved into the category of a satisfied patient. And that's basically the study, but I've got a couple other things I wanted to talk to you about. I don't want... Sorry. Yes. Some had it for years, and some were relatively recent, and you'll see some interesting things here in just a minute. I don't want to insult you about how to do breast augmentation, but I basically modified the way I do the procedure based on the belief that the majority of capsular contractions are biofilm generated. If you want copies of any of these things, I'd be happy to go over them with you. There's nothing there all that dramatic. Chlorhexidine alcohol prep is clearly the star as in terms of that. The antibiotic rinse during the surgery, there's 2 of those, so they were both described very well in a paper by Dr. Adams. If you use the one that uses the povidone iodine, according to the FDA, you have to rinse that out before you put the implant in. Your choice. Both of them are very, very effective. Capsular contracture surgery, this is a little bit different. So, as I said, 7 of our patients went back to and had capsular contracture surgery. A few more patients are pending. When you do the capsular contracture surgery, if you believe that biofilm was the principal cause of it, absolutely every speck of the old capsule has to be removed, because any portion of that, it takes such an incredibly small number of bacteria to regenerate the biofilm and regenerate the capsular contracture. You've got to get every speck of the capsule out. The exception being if you have a very thin person and the choice becomes pneumothorax or getting all the capsule out, you have to rethink that one a little bit. But when it's possible at all, every bit of the capsule has got to come out. Drainage if necessary, because one of the things that Dr. Wickstrom has said in previous talks, but he didn't get time today, is any blood changes the amount of bacteria it takes to get the biofilm started. So if you've got any kind of oozing and it's not being properly drained, you're asking for the biofilm to reform. He agrees. I'm quoting him actually. And it has to be a new implant. There's no possible way to sterilize. Even if you're using a smooth gel implant, which theoretically you should be able to scrub, the data shows that there's no possible way. You've got to use a new implant, which does not make the patients real happy, but nevertheless, it does that. Also based on some of the things that this got out of sequence a little bit, sorry. I wanted to show you this too. These were the patients that dropped out and why they dropped out. The first patient felt that she could do the same thing at home, was concerned about the cost of the treatments, which are minimal, $80 a treatment if you're doing both sides. Second one did not show any improvement, was not quite ready psychologically for the surgery, so she's pending. The third one came about 400 miles. She found me on the internet. She just thought it was too far to continue that. The last one got good improvement, but couldn't do follow-up. She's going to try and do it on her own. This is a little more controversial area. I've been giving our patients letters saying that if you're going to have dental cleanings or significant dental procedures or vaginal or rectal procedures, that you should have antibiotic coverage. I've already gotten 2 angry letters from family practice doctors and one from a dentist saying that this is not justified. But I think it is, and I've got a slide that I'll show you. This is a patient of mine that 2 days after having a dental cleaning developed hardness, redness, and tenderness in the one breast, and this is at 3 weeks. This is a fairly severe capsular contracture. I now have in my practice alone 4 patients that within 3 weeks of dental cleaning have developed capsular contractures. I took one of the big position statements that's frequently quoted, which is the American Academy of Orthopedic Surgeons, and they came down to, their conclusion was the risk-benefit cost-effective ratios, probably not in that order, fail to justify the administration of routine antibiotic prophylaxis. But what they're measuring is the wrong thing. This very august panel got together and they were talking about open, obvious inflammatory infections. And that's not a biofilm. So they're recommended that prophylactic antibiotics is not appropriate for, and it's true if you're talking about true angry, serious infections of the breast. I've been in practice 30 years. I've seen probably 4 of those in my life. And I agree with them that that's not justified for that. But they weren't talking about biofilms. And I think if you look at the American Heart Association recommendation, the Orthopedic Association recommendation, the Dental Association recommendations, where they say you don't need antibiotics for prophylaxis, I think they're wrong because they're looking at aggressive infection. They're not looking at biofilm infections. It takes a remarkably small number of bacteria, and it can take a significant period of time for the biofilm to show up. So based on some other things that Dr. Wickstrom said in one of his talks in DC, I developed this prophylactic treatment entirely on my own, kind of hanging out there on a limb. And what I decided was when I do the capsular contracture surgery, that I would treat them at 2 weeks and 4 weeks following surgery with the antibiotic regimen recommended by the American Heart Association, because truly the only antibiotic regimen out there for biofilm disease is infected endocarditis, because that is a biofilm disease. All the other protocols are not dealing with biofilm illnesses. So I took the American Heart Association's antibiotic recommendations. I treat with ultrasound at weeks 2 and weeks 4 following that. And I don't know how familiar you are with some of the capsular contracture surgery, but the capsular contracture surgery is pretty fraught with pretty high numbers of recurrence, as much as 50% in some studies. Of our 7 patients done over the 8 months, we have no recurrence. Obviously, we're going to continue to follow this, and I may go home tomorrow and find out that 3 of them have recurrences, but as of Wednesday evening when I left for this conference, all 7 of our capsular contracture patients have no recurrence. And after I showed this to Dr. Wickstrom, he thought that maybe my prophylaxis was a reasonable plan. American Heart Association guidelines, I mean, it's gone. It was revised in 2007. Now recommended a single dose, 30 to 60 minutes prior to an invasive procedure. All of those protocols are available easily online. If you want to ask me any more questions about how I do the capsular contracture surgery, or if you want to see my full list of what I do, basically 22 things I do differently in the operating room to minimize capsular contracture. That's my private email. Feel free to call me. I'd be happy to answer any questions. Did that answer your question for you?
I have one question, Dr. Kress, and that is, the patients that were closer to the onset of the capsular contracture, did you notice any difference in the percent in which it was effective if it was early onset when you saw them versus those who had had it for a long time, or were you, with the numbers, you weren't able to analyze it?
It's a very good question. He was asking me about the differences of how soon they were. I think I actually only have 2 patients out of the whole group that I got within the first 6 weeks or so of the onset of capsular contracture, so I probably wouldn't be able to make an intelligent assessment of that. But with your suggestion, that would be something that we continue to watch in the future, so as we develop more data, I should have a better answer for you. I feel comfortable answering it right now. Yes, ma'am.
You probably want to answer that. So she asked, so how is this sold and how does this work in that too? So I guess.
So essentially with the information that we have from Dr. Kress and Dr. Wickstrom, our company's protocol is essentially putting this system in the surgeon's or medical professional's office. Please do come see us. We're at booth number 1152. You can have a demo of the machine, and there's a lot more components to treating in your practice, and more importantly, the revenue aspect of this. We'd like to show you why this really shouldn't be a consolation prize for your patients. It really should be a huge revenue earner for you, and we'd like to show you how to make money with the system, as well as help your patients. So again, booth number 1152. And again, our company name is Aspen Rehab Technologies. We do have some DVDs and some brochures on the tables here if you'd like to grab it. Please do come by our booth though. We can talk in more detail regarding implant contraction and how we can help you out in your practice. We're going to close up, and I'd be happy to answer your question when I can get down to you and hear you. Thank you very much, everybody.